Welcome back to Diabetic Food Files. I had a little bit of an interesting weekend, but let's not go into that. So imagine someone, and today we're going to do Forgotten Infection Friday, but it is Saturday. So imagine someone comes into your clinic with a foot that has been swollen for years, not days, not weeks, years. The foot is enlarged, the skin is thickened, there are multiple little openings and draining fluids and you look at it closely, there's drainage, but you see these tiny grains, these little particles almost like sand. Maybe they're white, maybe some are yellow, maybe some are red, maybe some are blue. Not blue, let's be honest. Maybe some are black. But the patient tells you it doesn't really hurt. And that's where the story gets kind of dangerous because you're looking at a foot that may be undergoing this progressive destruction. And while the patient is still walking on it, still working on it, still farming, that's still living their life, perhaps they're living with it for maybe 5, 10, 15 years. Okay. So today we're going to talk about another fascinating infection, but I believe almost every podiatrist knows about this because it's quite common when they do it on board. And it's Madura foot, mycetoma. And we're going to go deep into that and we're going to talk about what exactly mycetoma is, who discovered it, why is it called Madura foot. I wonder if that's where Medea got the name. But, let me just, I don't even know how that dude got the name. But why, how it infects the limb and so forth. Okay. So today's story of Forgotten Infection Friday is Madura foot. Okay. So let's start with the name, mycetoma. And let me spell that. Mycetoma, mycetoma. And the words sound like it's a fungus. That's what you think when you see MYC, right? Mycosis, things like that, right? But that kind of traps you. And mycetoma isn't necessarily fungal. It actually has two major categories. Eumycetoma, so EU mycetoma, and that's the fungal form. And then you have actinomycetoma, and that's the bacterial form, and specifically the filamentous bacteria. And clinically, they can look remarkably similar. And that's important to know because you're not simply just looking in the foot and say, oh, that's Madura foot, right? Or say mycetoma. Right now I'm saying it wrong, but forgive me. But you've gotten halfway there because there's two different types, right? And the treatments have to be quite completely different for both. So the fungal mycetoma requires antifungal therapy, often combined with surgery, and the bacterial mycetoma requires prolonged antibacterial most likely. Antimicrobial is the broad spectrum. Remember, antibacterial is underneath that, right? But prolonged antimicrobial therapy. So the organism isn't just an academic detail, it helps determine what we do next. So for Madura foot, the classic triad is associated with mastoma is that number one, you have swelling, so a chronic subcutaneous mass. Number two is sinus tracts, so multiple draining openings. Number 3 are grains. They usually put that in things. So the drainage contains these visible particles, swelling, sinuses, grains, and that's really a classic picture of it. And the disease is often painless or relatively painless early on. That's one of the reasons why the patients live with this so long. Like it's so interesting that people are able to live with certain abnormalities or disorders because it doesn't affect them. And let's be honest, we don't go to the doctor unless we feel pain, right? We'll be like, oh, my back has been hurting me for like months, or our knee been hurting us for months because we just like, oh, let's just walk it off. But it's the constant pain, the recurrent pain that usually gets us back. But we have to remember, that's the thing that a lot of our diabetic patients have to deal with. They don't have that pain because the secondary of peripheral neuropathy. Okay. But let's go on to it. So who discovered Madura? So let's take a trip back in time because this disease has been around for a very long time. Descriptions of this has appeared in ancient Indian literature. So the HW, the WHO, notes that mycetoma was described in modern literature as early as the late 17th century, while older Indian texts describe the condition as anthill foot. No, I never heard that before. And in 18 before I looked it up, but In 1842, a physician and missionary named John Gill described cases in the region of Madura in southern India. And that's where he got his name, Madura foot, right? And came later in the 1860s, this general named Henry Van Dyke Carter, which is a cool name, right? It sounds like, definitely sounds very well off and like a character, a very rich character in like a James Bond, some things like that, right? But Henry Van Dyke Carter studied the disease and helped establish the fungal nature of the condition and popularized the term mycetoma. And historical reviews credit Carter with recognizing the fungal elements and describing the tumorous character of the disease. And this came another important aspect of it. And then scientists realized, wait, not every case was fungal. They said some cases are bacterial. And that's when, in the early 20th centuries, investigators began separating the disease into now what we recognize as acetoma, acetoma. Okay, I'm just going to spell it out. Actinomycetoma. Okay, and mycetoma. And when somebody says Madura foot, don't automatically think, is this fungal? This is already fungal, right? Think of mycetoma syndrome. And right now I'm saying wrong, but forgive me. So, what actually causes it? So the answer is environmental organisms entering through most likely trauma. So think soil, plant material, thorns, splinters, tiny punctures, barefoot agriculture workers, steps on thorn. That's why you have to ask patients exactly what happened, their environment. The skin breaks, the organism from the environment is introduced into the subcutaneous tissue, and the process begins. So the CDC describes mycetoma as an implantation infection that is caused by a certain fungal or bacteria found in the soil, plant matter, or water. And this is why occupational exposure matters, such as farmers, herders, agricultural workers, people working outdoors, people walking on their barefoot. We always tell our diabetic patients, please don't do that. I tell everybody, just don't do that, okay? But, they say practice what you preach. I like to be barefoot too, so forgive me. And people were partly exposed on soil or thorny vegetation, but this is not an infection that usually starts because somebody caught it from another person, okay? It isn't considered contagious from a person to person aspect, okay? So that's important to know. Don't say, like, I touched somebody with mycetoma and I caught it. No, that's, quite ignorant to say. You got to understand the actual disease and disorder and what's going on, okay? This usual story is environmental, secondary trauma, inoculation, and then chronic infection. So, the two personalities of Madura foot, right? Mycetoma. Right now I'm saying this wrong, but I'm just gonna keep going with it. Okay, so eumycetoma, the EU one, is the fungal one, the one that's most important. Organism for this one is Madurella mycetomasis. Okay, they have quite a few different other organisms that once you look up, you'll see why I'm not pronouncing it. There, one is called Falciformis spora. Okay, and these organisms form grains within the tissue, and some of the classic fungal grains are black, and that black grain is a major clue. But don't make the mistake of saying black grains equals fungus, right? Because diagnosis cannot rely rely on. You could tell I haven't done this in a little while, but diagnosis does not rely on color alone. Okay, acetomycetoma. I'm just gonna say actinomycetoma. Okay. So now we have the bacterial form, and this is the filamentous bacteria that is important, and it includes organisms. It can include the nocardia species, Madurae. They have a streptomyces one as well, but geography for this one actually matters. Different organisms dominate different parts of the world. And here's something clinically important: the bacterial one tends to be more aggressive and actually cause more earlier bone invasion than the fungal one. Okay. So if you have a chronic foot mass with sinus tracts and you don't want don't want to assume because it's been there for years, it's biologically slow. Some forms can be quite destructive. So, what are the grains? What are these classic grains, right? The grains, because we say draining grains, right? We're not talking about random debris. These grains are microcolonies or aggregates of causative organisms. So, together with the material associated with the host inflammatory response, think of these little organized communities as sitting inside the tissue, pretty much. Okay, and they're growing. They establish themselves and growing. That's why organisms are so interesting because we're organisms ourselves, right? And they're becoming these grains. That's what they are. They're surrounded by the body's inflammatory response, and this is the reason the infection can become so difficult to eradicate. So the grain color, remember I talked about different grain colors? So it gives you clues, but not the full diagnosis, okay? The fungal one may have the black grains or the white grains. And the bacterial one is more colorful. The bacterial one is more white, yellow, red, depending on the organism. Like I said, the Madura pelletary, that one is red, okay? And others are white. So, I mean, I think the bacterial one, the way my brain will work with this one, bacterial ones are like a rainbow, Skittles, kiss the rainbow, and then the fungal ones are usually black and dull. Okay? So, why does the foot swell? So, let's talk about foot swelling because, when we look at advanced Madura foot, sometimes the foot looks almost unrecognizable. The swelling is not just simply edema. The patient stood on their foot all day and got puffy type edema. This is a chronic inflammatory fibrotic process that's going on. And the organism has been sitting and, living its best life in the subcutaneous tissue. The immune cells and the immune system recognizes the neutrophils and macrophages arrive and inflammatory cells become involved. And then we have granulomatosis, inflammation that develops and fibrosis develops. And so now we have organisms, we have inflammation, we have abscesses. Our body is trying to fight off of this. We have sinus tracts, we have fibrosis, and we have tissue remodeling. Okay. Over time, it pretty much changes the foot architecture. The skin changes, the subcutaneous changes, the fascia changes, the muscles become involved, the tendon, the joints, everything becomes involved, and eventually bone. Okay. Like I said, it's quite aggressive, chronic, and destructive. So why does it destroy tissue so slowly? So this is a actually quite interesting and favorite question of mine. So why doesn't mycetoma behave like a acute bacterial infection? Why doesn't the patient present in 2 days with a fever, red hot swollen foot? We think historical things like that, right? But macetoma is a different biological battle. The organism becomes established in the tissue. The immune system tries to respond to it, but it doesn't completely eradicate the actual organism. And you can get this chronic interaction between pathogen and host immune response. And the organism forms the grains, right? The host mounts a chronic inflammatory response, and there is tissue destruction, there's fibrosis, the organism continues to persist, right? And the process continues. And this is more like a war that neither side completely wins, okay? And your body is just trying to keep you alive against this host, right? But the body becomes a battlefield when it comes to that. So the grain is like a fortress for this organism. Imagine the organism building a tiny fortress. We already know how important and how beneficial for the bacteria the biofilms are for the bacteria. But right now we're talking about a different bacterium and that uses the host, okay? And the grain becomes this concentrated collection of organisms surrounded by host-derived material, okay? So your body literally is kind of protecting it. So the immune system is trying to attack it. The neutrophils arrive, the reactive oxygen species are generated, the inflammatory mediators are released, but the organism still persists, and the surrounding tissue continues and becomes inflamed and eventually fibrotic. Now, research in brain biology shows that the host immune cells surrounding the organism, while the fungal organism can produce extracellular material and the mechanism can help them survive within the tissue environment, histologically, you can see the inflammatory reactions surrounding the grains, okay? And this is a phenomenon called splendore phenomenon. Okay, and let me just spell that one. SP like splendor, like Badori, and HOEPPLI, phenomena. Okay, and that is the esophin eosinophils. Okay, material surrounding the infectious elements. And when you look at the pathology, you're seeing the evidence of the battle. We already talked about how it can enter the foot, but like I said, the symptoms the patient may develop massive swelling, multiple sinus tracts, skin thickening, fibrosis, contractures, bone involvement, and loss of function. And in quite severe cases, amputation may become necessary. But the key is amputation is not the first chapter of this. It's often the final chapter when it's so severe that the advanced disease is where amputation may become the only remaining treatment for that patient, okay? And we talked about can somebody live with it for years? Yeah, for several reasons. So first, it doesn't hurt that very much, okay? So the pain is not always an alarm bell for that patient. It progresses quite slowly. The patient may adapt. The foot becomes little bigger over time, little bigger, and then a new draining opening appears, then another one, and the patient learns to just handle the draining. It's just like how they said when you put a frog in boiling water, it jumps out. But if you put the frog in like room temperature water, it slowly increase the heat slowly with time. It just learns to adapt and then it just eventually dies, but it doesn't notice the huge increase in the temperature, okay? So, the patient might keep the foot wrapped and keep working, continue walking. They normalize the abnormality, okay? Now, another thing that affects patients is that access to healthcare can be quite limited. So, mastectoma disproportionately, okay, and forgive me whenever I get tongue tied or like, okay, but affects the rural agricultural populations, particularly in resource limited areas. Okay, so finally, there's also a stigma. Okay, and it's quite interesting how some people try to make certain abnormalities into especially the really rare ones that people don't know about. That's one thing that kinda irks me a little bit is when people will be like, "Oh, it's voodoo, it's witchcraft and all that stuff," and they be like, "Oh, we can heal it with this and herbs and stuff like that." I was like, "That's kind of manipulative and unfortunate for the people that believe that. It's not fair to those people that you're taking advantage of them and making them think that it's a spiritual curse or things like that. It's not fair to the patient, okay? It's you're taking advantage of somebody, they need actual medical help. It's not right. Yes, there are spiritual aspects to everybody's life where like we're all spirits and souls, right? But when doing that, when it comes to medical disorders and things like that, I don't think people should be preying on people and saying, "Yeah, if you pay me this amount of money, I will break the curse of this wound or this disorder." I'm not feeling it, okay? I don't think it's right. It's manipulative. Now, can a person with diabetes get mastectoma? Now, in our world of diabetic foot files, yay, a person with diabetes can develop mastectoma, okay? But diabetes can complicate the clinical picture, okay? So, mastectoma is not a diabetic foot infection, okay? Diabetes does not cause mastectoma, but initiating the event, like let's say the patient's in the environmental inoculation through trauma, right? Diabetes can actually potentially complicate this already complicated situation, right? And historical and clinical literature identifies diabetes among conditions that predispose for more invasive and widespread infection. But we have to remember a lot of our patients have peripheral neuropathy, so they may not feel a puncture wound. And that's why we tell you check your feet every day, every single day. I would do it twice a day if it was me. Or, like the lady said, she said, when you're in the bathroom, use the mirror, put the mirror in front of your toilet so that you can see the bottom of the foot while you just, people, remember olden days or in movies, they would be like, oh, let me go get the newspaper and read while I'm in the bathroom. That's what, the men used to do, right? And now you're going to have to look at your foot. Yeah. How about that? So let's do a quick case. So imagine a 62-year-old male with diabetes having a chronic swollen foot. There is drainage, there is an ulcer, maybe a little bit of odor. They may be already given antibiotics. It temporarily improves, and then the patient comes back thinking that this is a chronic diabetic foot infection. But what it is, it isn't, right? So what if there is mycetoma underneath? Why does this matter? Chronicity matters. So we have to ask, how long has it been there? Right? How long has the ulcer been there? How long has the swelling been there? When did the foot start changing its shape? Okay. Did it begin with a puncture injury? Does this patient work outdoors? Does this patient like to be barefoot? Have they lived or traveled in a region where mycetoma, aka Madura foot, occurs? Are there grains in the drainage? So what other things can mycetoma, aka Madura foot, be mistaken for? So it can be confused with chronic bacterial osteomyelitis. It's quite interesting that people like to be like, that's my go-to, right? And then they find out it's a completely different organism. A chronic diabetic foot infection, foreign body granuloma, tuberculosis, acetomycosis, sporotrichomycosis, chromoblastomycosis, the fungal infections, tumor, chronic abscesses, okay? But the clinical lesson is a chronic draining wound does not automatically mean a diabetic foot ulcer, okay? And a chronic draining wound does not automatically mean osteomyelitis, okay? We have to ask what actually is it, okay? So what do we do when we diagnose it? Clinical suspicion is quite important and laboratory testing is required. The goal isn't merely is this mycetoma foot, right? The goal is what organism is causing this. Okay, so step one, we would have to examine the grains, right? If the grains are present, we have to examine them, send them off to pathology or microbiology, yeah, that's okay, for their morphology and the color and provide clues. Most likely we're gonna have to do a culture. So a culture, I would do a tissue one if it was me. Culture can help identify the causative organism and distinguish between the fungal form of Madura foot and the bacterial form. Now, histopathology. So a deep biopsy would show grains, granulomatosis, inflammation, neutrophilic inflammation, fibrosis, and tissue destruction. But special stains can help characterize if it's fungal or if it's bacterial. And then, you really want to get fancy, get the PCR. Okay. PCR and other molecular methods can help identify the organism, but not every place have these advanced technologies. Okay, let's be honest. But why does a deep sample matter? Don't rely on a superficial swab to answer deep tissue questions. That's a good, try to, I think nobody can go wrong when they're thorough. You can't go wrong with being thorough. People may say it's too much, but you know what? I've learned people who are too much and very thorough, they get the job done. Okay? I don't like people who are just like always trying to take shortcuts. What's the shortcut for? Why are you taking shortcuts with the actual person's life? Why would you do that? Why would anybody do that? I would be scared if somebody was taking shortcuts with my life and be like, "Oh, I have to get to lunch. Let me do this quickly." "What? Oh, okay." So, you know, don't ever do that. It's honestly, it's worth the time to take the time. You would want somebody to take the time with you if you had a medical abnormality, and they wanna find what's right. But, there's a clear distinction, and I've been able to see it. There are doctors who care and the doctors who really, really care, they do take their time because they're interested in it. They're interested in the pathology. They're here to actually help heal the patient. They want to heal. I get it, burnout, all that jazz. But, you know, uh, here's the thing. When I started residency, I was 6 weeks out of giving birth. Okay? You're still kind of be recovering. I You're first year resident, you're doing a lot, okay? Rarely you're rarely having breaks, okay? I lost a lot of weight because, when you're pregnant, you gain weight and, I lost my baby weight very quickly because of all the work, and yeah, you get burnt out, you get tired, whatever, but one thing I did is you just keep on working. I just kept, you know, just keep on doing because if you like what you do, it doesn't become work. It becomes just just it doesn't become work. It's just your life purpose, right? And I would hope that everybody who's in medicine, that's their life purpose, that they're not there just to make money and just to hopefully not be like a doctor death. Hearing that weird thing about that doctor who was like purposely killing people, that was quite odd. I don't understand it. On top of that, it seemed like the healthcare system's kind of protected him, and that's why he was able to persist and go to different places. It was very odd, but let me that was a tangent. So, when it comes to imaging, okay, let's talk about imaging. Imaging doesn't replace microbiology, okay? So, imaging help us figure out how far did the diagnosis go, right? How far did the disease go? Plain radiograph can help us evaluate bony destruction, especially a chronic one, right? Ultrasound can help us evaluate the soft tissue, but when in doubt, MRI it out. That's me. So I love me an MRI because I get to see everything. But you remember there's indications and contraindications, and if an MRI is even available, right? Even CT. Okay, CT can help assess even deeper tissues and bony structures. Okay, but MRI can help with soft tissue involvement, sinus tract, abscess, facial, fascial involvement, muscle involvement, tendon involvement, and bone, okay? So the WHO, right, the WHO, right, specifically identifies X-ray, ultrasound, MRI, and CT as useful for evaluating the extent of lesions and managing the plan for this type of diagnosis, okay? And there's a particularly fascinating imaging finding that sometimes is discussed with Madura foot, and it's called the dot in circle sign. And they say on MRI and ultrasound, this can represent the central grains with inflammatory tissue surrounded by fibrosis. Okay, so it's a beautiful radiologic correlation with the pathology. So the image is basically telling you there's a grain inside a circle of inflammatory and fibrotic tissue, which is super cool, right? So, what is the treatment? Remember, I said the treatment is different between bacterial and fungal. So, for the bacterial one, acetoma, mycetoma, the bacterial one, okay? Just remember that one. This usually calls for prolonged antimicrobial therapy. So Bactrim, they usually use Bactrim and other agents like amikacin and other ones. But this, I would lead this to infectious disease. Consult infectious disease. These are the kings of them. Okay. They know what to do. They can figure out the clearance, the liver, all that jazz. Okay. Love you, infectious disease. Okay. For the fungal one, they need antifungal therapy, okay? So that's another thing. Like I said, I don't like when people try to treat viral infections with antibacterials and don't try to treat a fungal with an antibacterial. That you gotta know what class, what category is causing the infection, okay? So if it's the fungal one, you need to something the commonly used agent is atraconazole, okay? And the course will be like 9 to 12 months, which is interesting, right? But like I said, get infectious disease on it, okay? And some large localized lesions will need surgical excision, antifungal therapies, and unfortunately, sometimes it might need amputation. So when it comes to the fungal one, they're both quite hard to treat. But how long does treatment take? Like I said, it takes a long time because it's slow and progressive. Okay. So what happens if you don't treat it? Yeah, I mean, it's going to progress. There's going to be fibrosis. There's going to be deep structures involved, bony involvement, loss of deformity, loss of function, disability, and possible amputation. Okay. So we're trying to prevent amputations. That's the whole point of this podcast. Okay. But putting it all together, let's see. Let's put it all together. So let's create a patient with diabetes, they have neuropathy, they work outdoors, they frequently walk without shoes. One day, thorn, puncture wound, they don't feel it, but they should have been checking their feet every day. 3 months later, small lump, no major pain. 6 months later, larger swelling. A year later, drainage. 2 years later, two openings, and eventually, the foot is dramatically enlarged. Now, imagine the patient entering the diabetic foot clinic, and there is a temptation to say this is a chronic diabetic foot infection. But our first correct response should be stop, take the history, look at the morphology, look at the grains, look at the geography, look at the patient's occupation, look at the trauma, look at the timeline. Okay. And these will help us create the appropriate diagnostic materials. Okay, because we have to take diabetes in context without it always being the cause of it. Okay, and yes, diabetes can change the pathophysiology of this because diabetes is so interesting. It pretty much affects everything, every part of the person's body. Okay, like I said, every chronic ulcer isn't just a chronic ulcer, okay? So, like, we have to consider if the patient have chronic swelling, does they have multiple sinus tracts, visible grains, years of progression, relatively little pain, okay? So, differential diagnosis, let's do a little rapid fire. Chronic bacterial osteomyelitis, yes, but it can mimic it, right? Is it a foreign body granuloma? Possibly. There's different things it could possibly be, but that's the whole point of being a physician, right? For us to have, that's the whole point of having differentials, and that's the whole point of, I would say, boards, for you to figure out all these different case scenarios and be able to diagnose appropriately, okay? Because limb salvage starts with diagnosis. Okay, so if you misidentified the organism, you may give the wrong medication. If you give the wrong medication, the disease continues. If the disease continues, it penetrates deeper, and then surgery becomes more difficult, and then eventually you may be left with fewer limb saving options. Okay, so the earliest limb salvage procedure anybody can do is recognizing the disease early, and figuring out what you're actually looking at. When it comes to prevention, just wear your shoes. Protective footwear, okay? Protective feetwear and checking your feet every day, okay? Catching things early is very great, okay? And big takeaways is that this is a chronic implantation infection, okay? Remember, there's two types of Madura flush, fungal and bacterial, okay? Not going to pronounce it, but we already know the fungal form is eumycetoma, and the bacterial one is actinomycetoma, okay? And the classic triad of this swelling, sinus tracts, and grains. Like I said, for the fungal one, the grains are going to be dull or black, but for the bacterial one, it's going to be kiss the rainbow. It's going to be Skittles. It's going to be different colors, red, yellow, white, cool, right? And yeah, honestly, early recognition can create an opportunity for limb preservation. Okay. So I want to end this episode with a picture. When you're looking down at a patient's foot, if they have a lump for years, they got used to it. It's draining, it's trapped. They're used to people staring at them. They're walking differently. They may have been told it's fine. They may have been given antibiotics. The drainage may have been decreased, but we have to understand the organism has continued to live in this patient's foot. So they form the grains, they provoke inflammation, they create fibrosis, they destroy the tissue. Okay. And this is what makes this type of diagnosis quite dangerous because it's not necessarily dramatic, but it is quite persistent, quite quiet, and quite slow. Okay. So don't just be like, aha, it's a diabetic foot ulcer. Oh, chronic osteomyelitis. Next time we see a chronically swollen foot, we have to ask, like, is there multiple drainage sinuses? That's the whole point of probing, right? I say when it comes to a, a nice hemostat, I love me a nice hemostat. Okay. You can use a pure app, but a hemostat, you could probe pretty well with that, okay? That's my method, okay? Everybody has their own method, comes with time and experience, but, you have to ask, what organism am I dealing with? What type of infection is this? How deep does it go? How low can it go? And can I save this limb? Because in limb salvage, time is tissue, like they say. And sometimes the difference between a foot being saved and a foot that can't is simply recognizing the disease before it becomes obvious. So this has been Diabetic Foot Files. I know I took a break, but I'm Dr. G, and every foot has a story. And take care of your feet because they take care of you.